of secretion of plasma vasopressin and increases in plasma vasopressin, and it involves thirst as a mechanism to regulate the tonicity. So in the setting of a water excess, plasma osmolality decreases to less than 280. You have a decline in plasma AVP or ADH that increases renal water excretion that then normalizes plasma osmolality. If we have a water deficit, plasma osmolality increases to greater than 290 or so. Vasopressin rises and we decrease renal water excretion. Thinking of it a little bit more physiologically, as we go along the nephron, the take-home message is that there are many nephron segments that play a role in the countercurrent mechanism and conservation of water. But in the setting of an antidiuresis, where we have an increase in ADH or vasopressin, we have a marked increase in urinary osmolality, so maximal maybe 1,000 or so in the setting of vasopressin. In the setting of a water diuresis, we have a minimum osmolality of 50 to 65 or so as we excrete tremendous amounts of free water. And how the kidney does this is through the architecture of the kidney, the fact that we have the vasorecta that are so tightly interposed with the tubules, the role of the thick ascending limb and concentrating mechanism, and the role of the collecting duct as the final common pathway of water reabsorption. And a key issue is this increase in interstitial osmolality in the collecting duct, in the papillae of the kidney. At a more molecular level, there are many transporters that play a role in setting up this countercurrent mechanism. And if you go along the nephron, aquaporin 1, the water channel in the descending thin limb of the proximal tubule, is a major player in allowing water to go across the cell into the interstitium. When that happens, sodium chloride increases in luminal concentration within the tubule. You get passive absorption of sodium chloride in the thin ascending limb, and then active absorption of sodium chloride in the thick ascending limb, which is water impermeable, these segments. And that is a major player in setting up this medullary interstitial gradient that plays a role in the collecting duct in absorbing water under the influence of vasopressin. We're not going to talk that much about urea absorption because there's not a huge amount of clinical relevance to it, but urea absorption under the influence of vasopressin also plays a big role in the concentrating mechanism and absorption of water. But I think the one picture that you want to remember in your brain in terms of water metabolism is the actual principal cell and how water permeability in the principal cell is regulated by vasopressin. So there's a gradient across the tubule lumen and the interstitium in osmolality. So water is going to run down the osmolar gradient from the tubule lumen to the higher osmolality interstitium. But it does so only if vasopressin stimulates insertion of active water channels, aquaporin 2, at the apical membrane. At the basolateral membrane, there's the V2 receptor that activates adenylate cyclase, increases protein kinase A activity that then phosphorylates aquaporin 2 and shuttles it to the membrane. So that single bit of physiology is the final common pathway in many disorders of sodium. Either a loss in this function in hypernatremia and polyuria, or a gain in this effect in the setting of hyponatremia. The other key physiological principle that I've stolen from one of Bud Rose's textbooks many years ago, and I think is helpful but maybe a little bit simplistic, is to remember that there are two different phenomena that are intertwined in hyponatremia and in sodium disorders. One is osmoregulation, whereas the other is extracellular volume regulation. So here in osmoregulation, we're sensing plasma osmolality. Here in volume regulation, we're sensing what used to be called effective circulating volume, but now is more effectively called effective arterial circulating volume. Hypothalamic osmoreceptors sense osmolality, whereas blood pressure and perfusion is sensed in the carotid sinus, afferent arteriole, and in the atria on a negative level to release ANP and BNP. The effectors of osmoregulation include vasopressin and thirst, whereas there are many effectors of volume regulation, the sympathetic nervous system, which increases salt absorption in the kidney, the renin-angiotensin-aldosterone system, which affects salt absorption all along the tubule, ANP and BNP, which negatively regulate salt excretion. But of course, the key thing is that vasopressin also plays a role in regulating volume regulation and perfusion. And this is where we get into trouble, because disorders of effective circulating volume will have an increase in vasopressin that causes a retention of free water and leads to hyponatremia. And that's where I think much of the confusion between sodium versus water occurs, is this single bit of physiology that vasopressin also helps defend arterial integrity. In terms of what we're affecting urine osmolality and water intake here. And here, for the most part, we're affecting urinary sodium excretion, but also to some extent vascular tone as well. If we think about vasopressin, it's worth, in terms of when we talk about the vasopressin antagonists, we need to remember that there are three different types of vasopressin receptors. There's a V1A receptor, which is widely expressed, plays a role in constriction of the blood pressure of blood vessels. It also plays a role in blood pressure control. There's a more restricted V1B receptor that's only in the anterior pituitary. And then there's the V2 receptor that is predominantly in the kidney, the renal principal cells, and thick ascending limb cells. As an aside, there is some expression of the V2 receptor in vascular endothelial cells, which is why DDAVP tends to increase secretion of von Willebrand's factor from blood vessels. And this plays a major role, however, for our purposes, just in water and sodium chloride absorption. When we think about hyponatremia, one other theme that I like to point out is that really hyponatremia is really a disorder of the central nervous system. It's a disorder in sensing of osmolality for the most part in most of the patients that we see, and it's a disorder of vasopressin secretion and to some extent also of thirst. So we need to remember the physiology of how osmolality is sensed within the brain. And there are what are called osmoreceptors in specific spots in the brain where the blood-brain barrier is relatively leaky and the neurons are exposed to the circulating osmolality. And that's in the organum vasculosum of the lamina terminalis, that's near the part of the third ventricle, and the subfornical organ. We don't need to remember that, but just remember that there are osmoreceptors within the hypothalamus that feed into the cells that produce vasopressin in the posterior pituitary and release vasopressin from the pituitary. So looking at it a different way, these cells, you have synthesis of AVP in the supraoptic nucleus and paraventricular nucleus. That AVP is transported to the posterior pituitary and then is secreted under an osmotic stimulus, in some cases modulated by non-osmotic stimuli, which is clinically relevant, for example. That vasopressin circulates and stimulates the reabsorption of water, ultimately in the collecting duct through that final common pathway that we just talked about in the kidney. Key issue, though, in terms of regulation of vasopressin is this relationship between vasopressin concentration and osmolality. So there's this inflection point at an osmolality of about 280, at which vasopressin all of a sudden becomes increasingly present within the serum. And as you increase osmolality, you get up to a peak of maybe 10 to 12 picograms per ml. The key thing that people need to remember is that that response is modulated by volume status. So if you take patients or subjects and you put them on a high sodium chloride diet and make them hypervolemic, chronically hypervolemic, that curve is shifted to the right. So you have a higher osmolality at which vasopressin appears, and there's a less steep relationship between vasopressin and osmolality, and you have less vasopressin appearing within the serum. If, however, subjects or patients are volume depleted, vasopressin appears at a lower osmolality, and there's a steeper response curve to the effect of osmolality. So clinically, if you have a patient that is hypovolemic and has an increase in vasopressin, and you give them saline, what you're really doing is you're moving them from this curve to this curve. So if you're at a constant osmolality, you'll see that vasopressin will plummet from, let's say, 5 picograms per ml to almost 0 at the same osmolality. The other important thing to remember is that vasopressin has an extremely short half-life. It's around 10 to 20 minutes. So that's why we can so rapidly change the physiology in a given patient. Just by reducing the hypovolemia, we can change this relationship on a minute-to-minute basis, and we can all of a sudden have no circulating vasopressin, and that patient's physiology is completely different just after a liter or two of saline. I think this is a better way to think about it than the way people talk about, oh, gee, vasopressin, if you remove 2 liters of blood volume, vasopressin goes up as a defense of blood pressure. That doesn't really explain the patients that we see every day with hypovolemic hyponatremia, whereas this kind of differential regulation is what does explain it. One thing that always bothered me as a medical resident, as a renal fellow, I was told all the time, well, you need free water intake to generate hyponatremia. And I kept wondering, if somebody's serum sodium is 120, why are they even drinking water? Because you'd think that their brain would be telling them not to take in water. And it turns out, in fact, that thirst is also abnormally regulated in SIADH and hyponatremia. But at the physiological level, over the same response curve, you also have an increase in thirst. If you look at the textbooks, they'll say that the thirst response is actually about 8 or 10 milliosms to the right. But basically, if you do it more carefully, the thirst response is identical to the vasopressin response. So as you increase osmolality and you increase circulating vasopressin, you also have a steady increase in thirst sensation, and you have a steady increase in water intake. And recently, as it was shown a few years ago, 7 years or so ago, in subjects with SIADH who had hyponatremia and had abnormal osmolar regulation of vasopressin, their thirst response was also shifted to the left. So this is the normal thirst response of the controls in this study, and this is the several patients that they studied who had hyponatremia from SIADH, and showed that at lower osmolalities, their thirst response was stimulated. And I think this is one of the reasons that we have such trouble in water-restricting patients with hyponatremia, is that they are intensely thirsty at the osmolality in which they're residing if you just increase it a little bit. So we need to be aware of that at the bedside, that thirst is also a problem in many patients with SIADH. So if we get to the bedside and we're evaluating a given patient with hyponatremia, I wanted to sort of think of how we approach these patients from step one. In the history and physical, we need to know their medications. And I think you and I have the clinical experience that SSRIs are probably the most common contemporary cause of SIADH. You need to know some aspects of their past medical history. Have they had prior pituitary surgery? Is this a patient who's likely to have secondary adrenal failure because they're hypopit? On review of symptoms, we want to look for symptoms that are attributable to acute or chronic hyponatremia. And we'll talk about what those symptoms are as we go through this talk. And one theme in this that's new is that chronic hyponatremia does cause some degree of symptoms if you look for it carefully. We also want to look for symptoms that are suggestive of a cause. So do they have profuse diarrhea, giving them hypovolemic hyponatremia? We also want to get some idea from the history of the chronicity. So is this acute or is it chronic? And physiologically, because of the neurological response to hyponatremia, chronic hyponatremia is defined as that's occurred for greater than 48 hours, as we'll talk about in a few minutes. On exam, we want to know, are they hypovolemic? I tend to really look for the hard data. Were they orthostatic, or did they have a reduced JVP? Or, on the other hand, are they hypervolemic with a high JVP, edema, and inspiratory crackles on chest exam? The initial lab evaluation of hyponatremia is also relatively straightforward. The key thing is to always measure plasma osmolality. We'll talk about a case at lunch where that wasn't the case, and it led to significant sequelae for the patient. So if it's low, it's true hyponatremia. If it's normal or elevated, this is pseudohyponatremia, or in the setting of a high BUN, renal failure. And you want to correct the measured osmolality for the effect of BUN by subtracting that and look for the effective tonicity in the absence of a high urea. Urine osmolality is critical in the bedside evaluation of hyponatremic patients. If it's less than 100 or so, primary polydipsia is the cause to a large degree, and those patients will correct rapidly. If it's greater than 100 or so, reduced water excretion is the major player. One exception to this is patients with beer potomania or low solute excretion, where they can have urine osmolalities that are less than 100 or so, or 100 to 200, as we'll talk about at lunch in a case, but they do have a defect in reduced water excretion. But that's it's a bit of an outlier in all the causes of hyponatremia. The urine sodium concentration is also critical. If it's less than 20, this is effective volume depletion. If it's greater than 20, they're euvolemic or renal salt wasting. You need to look at this in the clinical context, though. Clearly, if they have heart failure and they have a urine sodium that's less than 20, that doesn't tell you that this particular patient is hypovolemic. It's more suggestive of their having congestive heart failure. Some of the further testing, you need a TSH to rule out hypothyroidism. I always check a random cortisol to look for primary or secondary adrenal failure. It may be appropriate in some settings to do a cocentrosin stimulation test if we think primary adrenal failure is likely. A chest X-ray is very important in smokers in particular looking for a small cell lung CA. But the key point is that because this is a central tumor, you can miss it on a chest X-ray. So if you have a high index of suspicion in an SIADH patient, they should have a chest CT. Head CTs if you're looking for a CNS cause for SIADH and hyponatremia. And we have a case this afternoon that we're going to talk about where there was a cause of the hyponatremia that was evident on the head CT. So you need to look also at the sinuses and nasal cavity. You can get squamous cell CA or olfactory neuroblastoma as causes of hyponatremia. So we've done the bedside evaluation. We've examined the patient. Then we sort of break off into this very commonly used algorithm for our approach to hyponatremic patients who have a high urine osmolality. So there are three subsets. Those that are hypovolemic have a reduction in total body sodium, but an increase in total body water over sodium. The euvolemic patients who have total body sodium that's almost normal or slightly above normal, but their total body water is increased. And the hypervolemic patients who have an increase in total body sodium, but a greater increase in total body water, so their sodium is low. And this is the typical algorithm. This is taken from one of Tom Burrell's talks or papers. We then use the urine sodium as a major sort of toggle point in this algorithm. So if we look at the hypovolemic patients, if they have a urine sodium less than 20, they have mostly extrarenal causes for hypovolemic hyponatremia. They may have vomiting or diarrhea or third spacing of fluids, so on and so forth. If, however, they look clinically hypovolemic but have a highish urine sodium, they will have some renal loss of sodium. This may be primary renal disease, it may be adrenal failure, it may be cerebral salt wasting, which is a rare cause of hyponatremia in patients with CNS disease. So again, we always need to look at the clinical context. Is this patient, do they look like they're inappropriately volume depleted with a high urine sodium? Then they have some sodium wasting problem that is causing the hypovolemia and increasing the vasopressin and causing the hyponatremia. The euvolemic patients classically are said to have a urine sodium greater than 20. The caveat, though, is many elderly patients will have a urine sodium that's in the 20 to 40 range, but they are clinically hypovolemic and they will respond to saline with an increase in their serum sodium. So this decision point, urine sodium less than 20, isn't absolute. Many patients will have slight hypovolemia, won't have primary renal disease or sodium wasting, but will respond to saline hydration with an increase in their serum sodium. So here the differential is the syndrome of inappropriate antidiuretic hormone secretion, glucocorticoid deficiency and pituitary failure, as we'll talk about later this afternoon, hypothyroidism, any non-osmotic increase in vasopressin, be that from stress or drugs or other stimuli. Hypervolemic hyponatremia, if the urine sodium is greater than 20, this is mostly acute or chronic renal failure. If we look at urine sodiums less than 20, far and away probably the most common contemporary cause is cirrhosis. I think it's unusual to see a patient where heart failure is the only cause of their hyponatremia. This is mostly in patients who are pre-transplant, pre-heart transplant. we're so good at managing heart failure, everybody is on an ACE inhibitor and so on, and ACE inhibitors can increase serum sodium by helping your neurohumoral status in heart failure. So I think it's reasonably uncommon to see somebody where heart failure is the only cause of hyponatremia. Whereas I think most of the time when we see hypervolemic hyponatremia, it's primarily portal hypertension and cirrhosis. And nephrotic syndrome is also a cause in this setting. So if we look at these hypervolemic causes, what's the underlying physiology that leads to an increase in vasopressin? Well, this brings up this issue of circulatory integrity, which I think is an easier concept to think of than, quote, effective circulating volume. If you have a low output cardiac failure or pericardial tamponade or constrictive pericarditis or extracellular fluid volume depletion or a decrease in oncotic pressure or an increase in capillary permeability, as you'd see in sepsis, you'll have a decrease in cardiac output. That activates these receptors that we talked about that defend extracellular fluid volume and arterial integrity. You increase the renin-angiotensin-aldosterone system, you stimulate the sympathetic nervous system, and you also have an increase in circulating vasopressin. You increase your systemic and renal arterial resistance, you increase renal sodium retention, and you also increase renal water retention and vasoconstriction through the action of vasopressin. And in that setting, you maintain arterial circulatory integrity, but because you have an increase in vasopressin, you'll have some excess retention of free water, and you can develop hyponatremia. Cirrhosis is slightly different. So in cirrhosis, the primary abnormality that leads to sodium retention is thought to be a systemic arterial vasodilation. But you turn on the same physiology. So you'll turn on the renin-angiotensin system, you'll turn on the sympathetic nervous system, and you'll increase vasopressin. And in so doing, you get sodium retention, increase in resistance, water retention, and an increase in cardiac output. And you maintain your circulatory integrity, but at the expense of some increase in water absorption in hyponatremic patients. So if we go back to the bedside, where did this urine sodium of less than 20 come out? There's really one primary paper from many years ago from Denver where they took patients who were clinically judged to be euvolemic and they looked at their urine sodium before and after they gave them saline, and they looked at their serum sodium before and after they gave them saline. And the patients that responded to saline were felt to have clinical hypovolemic hyponatremia, whereas those that did not respond were felt to be subclinically euvolemic and were felt to have SIADH. And lo and behold, the median serum urine sodium was around 18 for the patients who responded, whereas the other patients had a much higher urine sodium. So this and a few other papers are really where this urine sodium of less than 20 comes out. There's several corollaries to this observation. One is, don't rely exclusively on the physical exam to decide if somebody is hypovolemic or not. You may have a patient who doesn't seem that hypovolemic and just has a subclinical reduction in their salt intake or whatever, and they are subclinically hypovolemic, and you don't see it on physical exam, but they'll have a lowish urine sodium, and if you give them saline, they will respond with an increase in their serum sodium. The other corollary is many investigators feel that to really make a firm diagnosis of SIADH, you should cautiously give patients, if they can tolerate it, a challenge with saline to see if they do correct or do not correct, just to make sure that you're not missing again somebody who may even have a high urine sodium because of inappropriate natriuresis, but really has a hypovolemic hyponatremia that gets better with saline. This brings us then to the extensive differential for SIADH, which I'm sure many of you or all of you are very familiar with. And this sort of breaks down into malignancy, CNS disorders, miscellaneous causes, drugs, and pulmonary disorders. Far and away, the most common malignancy that causing SIADH is small cell lung CA. It causes approximately 75% of the malignancy-associated SIADH. But many other tumors can do this. Sometimes these are neuroendocrine tumors where there's this link with small cell lung CA, and it sort of makes mechanistic sense that these tumors would be producing vasopressin. But just remember that small cell lung CA is far and away the biggest cause of tumor-associated SIADH. Approximately 15 to 20% of patients with small cell lung CA will have severe hyponatremia, so sodium less than 125 or so at presentation with the disease. So I think this is a very common cause of SIADH that we see in this day and age. In terms of CNS causes, there are many, many causes. Infections are obviously important. Bleeding. This is a very common process after subarachnoid bleed to have either cerebral salt wasting or more commonly SIADH. So this is a common problem in neurocritical ICUs and so on and so forth. Again, as we mentioned in terms of drugs, far and away the most common cause of drugs are SSRIs. Anything, though, that modulates serotonin levels up will give you SIADH because serotonin seems to activate these osmoreceptors that control vasopressin secretion. So serotonin agonists, there are several that are now being tested or used. Ecstasy, which is a profound serotonin agonist, will also increase vasopressin. Some of the drugs in this list are in parentheses. NSAIDs are one of these. NSAIDs don't really increase your vasopressin, but what they do is they increase your renal sensitivity to vasopressin. And we'll go through that physiology later today at lunch when we talk about a patient with exercise-associated hyponatremia who is taking an NSAID. Chloropropamide is the same. It's really a sensitizer. It increases the renal sensitivity to vasopressin. Finally, we're left with pulmonary disorders. These are infections, bacterial and viral pneumonia, pulmonary abscesses. Tuberculosis is a very important cause of SIADH, and so on and so forth. One interesting issue in vasopressin is in SIADH is that there are several different patterns of vasopressin release in SIADH. And this has been known for many years, mostly due to the work of Gary Robertson in Chicago. So he found 4 different patterns of vasopressin release. In one of them, it was unregulated and erratic, had no clear and consistent relationship to osmolality. In the other one, there was a baseline increase, so there was a little bit of baseline vasopressin always present, but then you had a normal osmotic response. This should be C, I'm sorry. This third form is the reset osmostat, where you have a change in the threshold to the left, so you increase vasopressin secretion at a lower osmolality, and you have this relationship at a lower osmolality. Finally, there is a very uncommon cause where you have no circulating vasopressin that's detectable. And at the end of the day, we'll talk about one of the causes of this, which might appear on the boards, where patients have nephrogenic SIADH due to an activating mutation in the vasopressin receptor. So their vasopressin levels are appropriately suppressed, but they just have a gain of function in the receptor itself. So we'll talk about a quick clinical question. A 19-year-old woman is brought to the emergency department with altered mental status. She had been at a rave the night before. She became drowsy at around 2 a.m. and vomited several times. At 4 a.m., she had a generalized seizure that lasted 15 seconds. On exam, she is unresponsive. She's ventilated with a heart rate of 84 and a blood pressure of 145/85. Her heart sounds are normal. She has inspiratory crackles on chest exam. Head and neck is within normal limits. No evidence of trauma. And in the emergency room, you've got limited data, but you're told that the serum sodium is 121 with a depressed serum osmolality. So which of the following is a likely cause of this syndrome? Ecstasy-induced hyponatremia, hyponatremia secondary to seizures, exercise-associated hyponatremia, accrued intracerebral bleed, or compulsive drinking. Well, we don't really have any evidence that this is the case. She doesn't seem to have had an intracerebral bleed. Neurologically, as far as we know, she hasn't. Obviously, you would want to have a CT scan at some point. Exercise-associated hyponatremia is reasonable. She's been at a party. Maybe that's part of the problem. Hyponatremia secondary to seizures, well, actually, it's usually the other way around. You have a seizure because of hyponatremia, or this is ecstasy-induced hyponatremia. And the key here is that she's been at a rave. And for those of you that know, that's what you do at a rave, you take ecstasy. So this is a case of ecstasy-induced hyponatremia, which has been reported many, many times over the last few decades. This is really an interesting syndrome. It's sort of acute hyponatremia in a pill. It causes a marked increase in vasopressin within minutes. So these are normal volunteers who were given one pill of ecstasy, and then within 4 hours, look at the increase from normal or unmeasurable. It's at the highest possible amount in this particular patient. So ecstasy really does cause SIADH. It has many other factors that cause acute hyponatremia, however. You get this acute massive increase in AVP. Serotonin activates these central osmoreceptors at the physiological level. So you get this rapid increase in AVP release from the posterior pituitary. If you take rats and give them ecstasy, you see a neuronal activation in those osmoreceptor neurons that cause vasopressin release. You also get an acute stimulation of thirst, again because serotonin activates these common central osmoreceptors. So there are case reports, for example, of people that took 7 tablets of ecstasy, came to an emergency room because they had second thoughts about their overdose, and then drank 3 liters of fluid because they were so thirsty and became acutely hyponatremic. There was also an issue early on when ecstasy was given, because it causes rhabdomyolysis and many other disorders and can cause heat prostration. People that went to raves were told to really aggressively hydrate themselves. And I think this sort of hid this issue of acute stimulation of thirst from ecstasy, because people were actually told to take in a lot of free water if they were taking ecstasy at raves. But this leads us to a specific differential that we always should have in our mind, is of those patients with acute hyponatremia. And it's extremely important to separate out the people clinically that have acute hyponatremia, because the management is so dramatically different. This includes iatrogenic causes, postoperative causes, particularly in premenopausal women who are given hypotonic fluids. That's the classic cause of acute hyponatremia. Or any administration of hypotonic fluids when you have an increase in vasopressin. We're taught that these glycine irrigants that used to be used in TURPs and uterine surgery don't give you true hyponatremia, but many people have shown that they actually do give you a true hyponatremic syndrome. Many patients have been reported with acute hyponatremia after colonoscopy preparation. And this is all types of colonoscopy preparation, be it PEG-based or phosphate-based. One concern is people are being told now to take a bottle of Miralax and put it in a whole bottle of Gatorade and use that as their colonoscopy prep. And that really is a much more hypotonic preparation than other forms of colonoscopy preparation. And there's some concern that that may be something that will predispose patients to acute hyponatremia. Simply starting a thiazide can give you acute hyponatremia, and we have a case that we're going to talk about at lunchtime. Any cause of polydipsia that's extreme, many of you may have heard the We for a We contest a few years ago where a woman died from acute polydipsia and cerebral edema. Ecstasy ingestion that we talked about, exercise-induced hyponatremia that we'll talk about at lunch. Or I think more commonly it's a multifactorial cause. So somebody's on a thiazide and for whatever reason they have an increase in their water intake. So the symptoms and signs of acute hyponatremia are extremely important to recognize. Some people sort of subdivide these into early, advanced, and far advanced. But just be aware that patients can come in without much symptoms and then suddenly have a more advanced symptom of hyponatremia. So they may look reasonably well, but have a seizure in front of you from the acute hyponatremia. Far and away, the most common symptom is nausea and vomiting. Later on, they can develop a headache. Far advanced causes include dilated pupils, seizures, respiratory arrest, polyuria due to a central DI, or hyperglycemia is a very late complication of acute hyponatremia. One of the key issues is that for some reason there's a female preponderance of acute hyponatremic encephalopathy. So if you look at patients who have male patients with patients across the board with hyponatremia and brain damage, the majority, 97% of these are female patients. And it's not entirely clear why this is. There are many various conjectures as to why there's this female preponderance of acute hyponatremic encephalopathy. The other important issue is that in acute hyponatremia, you can develop hypoxia. This is really critical because a hypoxic brain is less able to cope with the volume injury of being acutely hyponatremic. And this has been shown in many patients with hyponatremia with an average sodium of 112 or so. Their average arterial PO2 was 38, and 83% of them had brain damage. This is from Alan Arieff's long-term series. So just to give you a clinical example, this is a patient with acute exercise-induced hyponatremia who presents with acute hyponatremia, tremendous cerebral edema on head CT with no sulci visible, basically, and neurogenic cardiogenic pulmonary edema. With resolution in the hyponatremia, the chest X-ray cleared and the MRI cleared. This is a patient who ingested ecstasy. This is a fatal case. The patient came in with a sodium of 117 in florid neurogenic pulmonary edema. So this is not cardiogenic. When people have measured wedge pressures in these patients, they're normal. And this goes away when the hyponatremia is resolved. We'll switch gears a little bit and talk now about chronic hyponatremia. Physiologically, this is defined as hyponatremia that's been present for greater than 48 hours or of unknown duration. And the key issue is that the CNS response to hyponatremia induces a sensitivity to the correction rate with respect to osmotic demyelination syndrome, as we'll talk about in a few minutes. The symptoms, largely because I think it's been so ingrained in us to avoid osmotic demyelination, I think everybody is taught that chronic hyponatremia is not symptomatic. That's not entirely true. You can see symptoms in patients who are, in fact, chronically hyponatremic, so they've been hyponatremic for more than 48 hours. These can include nausea and vomiting, muscle cramps and weakness, ataxia, confusion or change in mental status, and if the sodium is very low, maybe less than 120 or so, there is a risk of seizures, but nowhere near as high as the risk of seizures with acute hyponatremia. How does the brain respond to a hyponatremia? If you expose the brain to water, a normal brain is exposed to water. If you have acute hyponatremia, you have a water gain in the brain in this enclosed space. You get a rapid adaptation where the initial response is a loss of sodium, potassium, and chloride. And part of that's just from the cells, but part of it is actually also from the cerebral spinal fluid. The slower response is to lose organic osmolytes from the brain so that you're adapted to this lower osmolality. The problem is that if you rapidly change osmolality, this response is asymmetrical. So it takes a lot longer to regain these osmolytes if you have normal osmolality than it does to lose them. And that's to a large degree why patients can then get osmotic demyelination if we rapidly correct their hyponatremia. And this is what you don't want to have happen. You don't want to see central pontine myelinolysis or from osmotic demyelination syndrome. So far and away, the most sensitive area of the brain to this injury is within the pons. If you look at the accumulation of osmolytes after you increase osmolality after hyponatremia, this is one area where it's particularly slow. So this area is predisposed to injury if you then correct patients too fast. These patients can get flaccid quadriparesis, symptoms from their coracospinal tract involvement. They can get dysphagia from involvement of the corticobulbar tract. They classically can have a locked-in syndrome. And many of them, maybe 30% or so, will also have extrapontine pathology, which can give you things as varied as a Parkinsonian syndrome. That's usually in the setting of associated pontine myelinolysis, but occasionally is seen in the absence of pontine myelinolysis. So now we've switched to this other term of calling these patients suffering from osmotic demyelination. So the risk factors for osmotic demyelination are primarily the rate of correction, although what's always a little bit unnerving is you can get this if the osmolality is corrected at accepted rates of correction. Hypokalemia predisposes to osmotic demyelination, as does alcoholism, malnutrition, and liver failure. And you get similar changes in the same cerebral osmolytes in liver failure, so this is partly why in correction of liver failure you can get osmotic demyelination. I always found this a very puzzling disorder. Why would you get osmotic demyelination because of these volume issues when you change serum sodium back to normal? Well, it turns out to be very complicated. One of the things that happens is you disrupt the blood-brain barrier. That allows antibodies, complements, cytokines, and cells and so on to get into the perivascular brain and give you sort of an immune-mediated demyelination. One thought is this delayed induction of osmolyte transporters after correction of osmolality. Delayed induction of these osmolyte transporters that decreases your osmoregulatory capacity and leads to cell swelling and death. There are also suggestions that there may be apoptotic or excitotoxic cell death after correction of hyponatremia. Regardless, it's been known for now many decades that if you take patients with chronic hyponatremia and you rapidly correct them, you have a much higher incidence of permanent sequelae than you do in acute hyponatremia in those patients that are rapidly corrected. So I think over many, many years there's been this consensus that it's the rapid correction of chronic hyponatremia that is a major risk factor for osmotic demyelination. So I think this is one issue that has been set in stone, that chronic hyponatremia, you need to be very careful about correcting it too fast. And the corollary to that has been, well, because it's pretty asymptomatic, you don't need to worry about it. Well, one paper 5 years or so ago sort of set that on its end. They took 122 consecutive asymptomatic hyponatremia patients with chronic hyponatremia, variable sodiums from 115 to 135. What was interesting, these patients had all presented to a medical emergency room in Belgium. What was interesting was that the prevalence of falls in these patients was 21% versus 5% in disease and age-matched case controls. Often the fall was the reason for the admission. In the paper they didn't define what types of falls and so on.